Okay, so it is actually 9:01, so I'm going to go ahead and kick us off and get us started. So welcome everybody. Thank you for joining us today. It is Thursday, October 8th already somehow. I'm not entirely sure how it's October, but turns out it is. And like 85 degrees outside, so there's that. My name is Candace Bailey, and I am the Community Options Benefits Section Manager, and I am here with Kira Acuna, who is the Adult Day Specialist benefit manager amongst other many benefits. I also have Cassandra Keller here, who's the supervisor for that unit, here assisting me. John Berry is listed on the slide because he is always listed on our slides because he is our renowned facilitator. However, he is actually on vacation today, so good for him, well-deserved, and so I'm going to do my best to actually facilitate. Forgive me, you all know that I'm not near as good at it as John is, so hopefully you can just give me some grace and be excited when John returns. Today we are going to be talking about day program services for the HCBS waivers, specifically the adult day services in 4 of our adult waivers. Next slide, please. As always, we like to ground ourselves and start off with our mission, which is improving healthcare access and outcomes for the people we serve while demonstrating sound stewardship of financial resources. Next slide, please. The purpose of today's meeting, today we're hoping to engage you all in the adult day services changes that were put in place as a response to COVID-19. We want to receive some input and suggestions, some ideas on the flexible service delivery, including specialized adult day services, and we want to also receive some feedback on some of the proposed changes that we would like to make to adult day services. I'll remind everybody that questions can be taken either verbally via the computer or phone, or via the chat box. I have Kira who will be helping me with responding to some of the chat box questions. I will try to go through and read those out loud as well. I'll take some natural pauses and welcome verbal comments and questions as well during certain portions of the presentation. Next slide, please. So today's agenda. So this is how we are going to go through things today. So first we'll review the last stakeholder meeting, kind of give some highlights of that one. Want to receive some feedback and discuss on the tiered approach that we have implemented and see how things are going thus far, albeit still really, really new, we realize. We want to discuss the flexible service delivery options for specialized adult day services. We want to propose or show you all some proposed changes to the adult day services regulations. Keep in mind that while this flexible option that we've put in place right now is a direct result in response to COVID, we actually want to keep it long-term and post-COVID, and so in order to do that, we have to actually change our regulations going forward. And then we'll talk about next steps. Next slide, please. Okay, so first a quick recap of the September 24th meeting. During that meeting, we reviewed Operational Memo 20-091. Keep in mind that this was actually previously Operational Memo 20-087, and the 091 was just some corrections that we had actually made based off of feedback from you all, so we appreciate that. So we went through that memo, clarified the previously issued guidance, so clarifying things that, in fact, 2 units of adult day services is anything over 5 hours, not the 6 hours as we had erroneously stated in that first memo. We received some feedback and discussed some of the feedback on the tiered approach and structure. And then we discussed a little bit about some flexible service delivery options for specialized adult day services. The meeting from the 24th is posted online. If you all would like to go back and take a listen to it or take a look at the slides, that is online, and I'm sure Kira can find the link for you and post it in there in the chat box for you. Next slide, please. There's the post. She's super quick. Thank you, Kira. Okay, so just a quick review of the structure, the 3-tiered structure as we're calling it, that we want to go over. Tier 1 is really the only thing that's new. We're calling Tier 2 and Tier 3 as part of the tiered structure, but those are kind of how services have been authorized. It's just the difference of the 1 unit and 2 unit. So Tier 1 is allowing now a 15-minute unit of virtual or in-person adult day services. This would be up to 12 units or 3 hours a day, and it certainly waives some of the requirements of a facility-based setting, such as the lockers, showers, meals, unless, of course, you're providing in-person services around mealtime, things like that. Tier 2 is still the 1 unit, so it's 3 to 5 hours, and you have to meet all the standard ADS requirements. It can actually be combined with Tier 1. And then Tier 3 is 2 units, so it's essentially a full day, anything over 5 hours. And again, the requirements still have to be met for that as well. And it cannot, because it is over 5 hours, it cannot be combined with Tier 1. Next slide, please. Okay, so feedback on the 3-tier structure. So what we're hoping to do is have some folks that perhaps have been able to implement this structure. I think most of you have kind of done some variation of this, albeit not necessarily in 15-minute units during the entirety of the pandemic thus far. But I'd like to know, how it's working, what is going well, what isn't going well, what do providers like, what do members like or dislike. The other question is 3 hours enough? Is that sufficient for Tier 1? If it's not, we'll have to kind of rethink our combinations and things like that, but it's still an important question. We want to make sure that folks have a chance to think about and provide information. Do members utilize both Tier 1 and Tier 2 in the same day? So are you finding that folks are utilizing both of those services? Are members comfortable with returning in-person services yet? I know that there are a number of people that just still aren't comfortable with going out in group setting, which is, of course, 100% acceptable. But I'm interested to hear if you guys are having members that are feeling comfortable in returning to services. And are there any other modifications or things that we should consider for this 3-tiered structure? So I'd like to open it up. Please feel free to enter your comments, questions in the chat box. Please feel free to speak via your phone if you're on, or via your computer if you're on the phone. Let me know and we can take some verbal comments as well. Is there anybody that would like to make a verbal comment or ask a verbal question? We'll start there. Okay, not hearing any. I'm going to go to the chat box and start going through those. Alec has asked, has HCPF gotten some adult day utilization data since the last webinar? If not, what is your view of the current utilization of services? So we haven't actually at this point. We've been running literally from stakeholder meeting to stakeholder meeting, so we haven't had a chance to get any utilization data thus far. We're hoping to start gathering some of that here pretty soon. But so I don't have the answer to current utilization. I'm not sure what it looks like, which is one of the reasons why we're asking you all if members feel comfortable with returning or if you're having members return to services. Let's see here, premature ADC, did you know that your question line email is not working and all my emails come back with an error? Okay, so perhaps it is working because we actually are getting emails from that coming into that inbox. So perhaps, Kira, you can retype that email inbox. Keep in mind that there's some underscores in between. So it's HCPF underscore HCBS underscore questions at state.co.us. So it's the underscores, those are very important. But we can type that into the chat box for you all. There you go. Thank you, Kira. And you should just be able to copy and paste that into an email and it should come through. If it still doesn't work for you, please feel free to reach out directly to either myself or Kira with specific questions around ADS. All state employees, it's their first last name at state.co.us. All right. What other questions or comments? Do I hear somebody on the phone?
Candace, can you hear me?
I can.
Okay. Hi, it's Alec here. Sorry, still figuring out how to work the technology here. Just wanted to give feedback from Alpine's perspective. So
I would appreciate that.
In terms of the 3-tier structure, so we do have clients that utilize Tier 1, but it's kind of has been diminishing as we've seen a slight uptick in people who are attending in person. Who want to come back, and on some days we knock up against our capacity restrictions. On some days we don't. We've yet to see somebody who utilizes Tier 1 and 2 on the same day. Our experience, at least how our program is designed, is that once people get there, they want to stay the whole day. They want to get all 3 meals that we serve. They want to participate, in person if they're already there. So the trend for us was an increase, a slight uptick in in-person attendance, but of course we don't know how long that's going to last, given that COVID cases are also on the uptake. So both tier 1 and tier 2 and 3 have been useful. The one problem we actually ran across, it's more a misunderstanding, when we requested tier 1 units for most of our clients who did not yet feel comfortable enough to return attending. The SCP actually, gave us the request that roughly half of the units available because of the 3-hour limit in tier 1, but then suspended everything else in tier 2 and 3. So
Oh,
if
okay.
we're waiting for feedback. They wanted to raise it with you. I kind of told them I didn't think that was the intention, because then tier 1 and tier 2 on the same day would not be possible. But other than that, it all went pretty smoothly so far. The biggest issue is we just, can't get enough people due to the capacity restrictions to run the business profitable.
Yeah, yeah.
Maybe I'll leave it at
That's
that for
really
now.
helpful, and I appreciate you providing your experience. It's interesting that to hear kind of the trends that you guys are seeing, and we certainly can clarify with the steps around the unit limitations, because you're right. There would be no sense in reducing tier 2, because then that completely negates the process or the policy that we allow tier 1 and tier 2 to be provided together. So we can certainly provide that clarification to them as well. And of course, if you run into issues, please feel free to reach out and CC the SEP, and that way we all get the same information and we can reply to you guys all at the same time as well. Sometimes that's really effective, and rather than waiting for another stakeholder meeting. So what I'm hearing you say is that obviously the capacity limits are limiting for all agencies. We understand that. That is a health department requirement and limitation right now, because this virus isn't over. This pandemic isn't over. It's nowhere near over. And so that's kind of how the health department is addressing that. But outside of that, it's been helpful to have the variety of options is what I'm hearing. Is that accurate?
Sorry, yes, yeah, I had muted myself. Sorry.
Okay, great. Well, I'm glad that it's helpful. And like I said, I think this is brand new, and so I appreciate your point of it was more of a misunderstanding, and we are happy to help in any way possible. And like I said, we'll reach out to the staff to make sure that they understand how this process works as well. But as you guys come across it, because it is new for all of us, please feel free to, email us, and then we can make sure we're all on the same page pretty quickly. So thank you so much for your feedback. I really appreciate it. Let's see here. And there's another question in here from Prima 2. What can be billed under Tier 1? I see Kira answered it, but I want to just read it out loud just to make sure that everybody realizes that Tier 1 can actually be either virtual or in person. It can be either. So thank you, Kira, for responding. And also just to clarify around the capacity, is the current capacity limits that the health department has set is up to 50% capacity or 50 people per room. So that's, everybody has a different building size and how that works. But that is actually the current capacity limitation set by the health department. Let's see here. We have another question from Prima. Can you give us an example? Also under Tier 1, we have 15-minute units, which comes in at just over $10 an hour. How can we financially reimburse this service? Our employee salaries are more than that. That is one of the limitations that we have, and we are aware of it, is that the Tier 1 is fairly low, which is one of the reasons why it's more likely to be provided virtually in a group setting. So you could have one staff providing a virtual service to multiple members at the same time. It is, we are in a significant budget shortfall right now, as everybody is aware. The state is estimated to be at a $4 billion shortfall this current fiscal year. And so we didn't have a whole lot of leeway as far as the rates go. We were looking more to be able to provide options and flexibility. Previously, before implementing the Tier 1, if your agency provided anything less than 3 hours of services, you couldn't bill. That just wasn't an option. So we were hoping to be able to open that up and provide some more options and flexibility for all agencies, so that if you provided less than 3 hours of services, that you could still get reimbursed for it. And then, some examples. I'm not sure exactly what you need an example of. So if you could help me with that and understanding what kind of example you're looking for, I'm happy to see if we can't think through. And perhaps some other providers have some really great examples and ideas as well. I have found during these meetings, the day program providers are probably some of the most innovative folks that we've seen during this pandemic, and the things that you all are implementing and the way that you are effectively serving members has been just so amazing. And so, perhaps as far as the examples go, we could have some others provide some ideas of things that they've done, because you guys have just come up with some amazing things. Okay, so Lori is asking, are you aware of any local health departments, for example, Tri-County, that's guidance contradicts the state guidance? I am not, as far as opening. No, Lori, I'm not aware of any local health department that contradicts any of the state guidance at all. So if you come across that, I had encouraged you to specifically reach out to your local health department, of course, and CDPHE, but I have not heard of that at all. And I see multiple people still typing, so we'll see if a couple more come through before I move on to the next portion of the, actually, I think the next one is for the, can you go to the next slide, please? While we're typing on that, because this is another review and another opportunity for more feedback and conversation. So for the brain injury waiver, because the limitations as far as the hour units and things like that were slightly different, we actually implemented a 2-tier structure instead of the 3-tier structure. So Tier 1, which is the new one, again, is 15-minute unit of virtual or in-person adult day services. This is limited to 2 hours a day, because over 2 hours is the 1 unit of the traditional brain injury ADS. So again, this would waive some of the requirements of facility-based settings. And then Tier 2 is the same. It's kind of business as usual. It's anything over 2 hours. Next slide, please. And then, so just wanted to move on to make sure that we're gathering feedback. Kind of, it's the same idea around the 2-tier structure. If we have any brain injury providers, I'd be interested to hear from you as well, not shutting off the conversation on the 3-tiered structure. So if folks still want to comment on that, I would love to hear from you. But wanted to check in and see how this is working. If we have folks that are using the Tier 1 services, if they feel like those services, the hour limits are sufficient, and are there any other modifications that we should be considering? Let's see here, and I will see one question in the chat box. Allison Burns asked, will you please clarify what you said about program capacity? Certainly. So based off of health department regulations, limited healthcare settings, which is what adult day services are considered, are allowed to open at 50% capacity at this point in time. So this is a health department regulation and limitation. So this is for all counties are kind of now able to venture into their own phase, if you will. So if you remember, we had our stay-at-home order, then we had our safer-at-home order, and then it was safer-at-home in the vast great outdoors. And then the health department and the governor's office put out the last phase, which is the protect our neighbors phase, and allowed the counties, based off of current infection rate within that county, to make the move into phase 3. We only had, I think, 2 or 3 counties that officially moved into that phase, which had far fewer limitations on gatherings and things like that prior to the start of the resurgence after Labor Day. And so they actually put a halt on having counties move into the phase 3. So most counties are still in the safer at home and the vast great outdoors, which has a significant number of limitations on openings and things for, for all businesses, really, restaurants, limited healthcare settings, things like that. One of the limitations for limited healthcare settings is you may only open at 50% capacity or up to 50 people per room is what the setting says. And Kira, could you provide that link for folks too around the guidance that was put out by the health department? That would be very helpful. Let's see here. It looks like there was another question that perhaps I missed, and my apologies, about food stamps from Prima. I don't see that one. So perhaps somebody could help me with, oh, here it is. I'm sorry. Many of our clients had received raise in food stamps and are wondering if their participation in the daycare will reduce their food stamps or SSI. I can't speak to food stamps. I have no idea actually how that's calculated, or if that would change if they start going back to adult day services regularly all day. I'm just not sure. It shouldn't change their SSI payments. That's actual living payments, but they would have to check with the county on that. My apologies. Okay, and so Christy Broughton asked, does the application of limited healthcare settings apply to day habilitations and the IDD waivers as well? The answer is yes, Christy. That was the best fit for all-day program. Tamara is a 50% based on attendance prior to COVID or based on square footage. It's based on I wouldn't say necessarily attendance, but because you could have, you could have been able to serve. It was based off of how many folks you were able to serve. So, for example, restaurants, this is just an easy example to state, have a building capacity of 100 people. They could have actually served 100 people at a time, but they now are only able to serve 50, for an example. So if you have enough staff and you were previously able to serve 100 people, you could now serve 50. However, if you typically only had 80 people, because that's just all the number of clients you had, but you could have actually served 100, I believe that you could serve still the 50. Kira posted the guidance that CDPHE put out. It's the health department guidance specifically around that. If you have really specific in-depth questions around this guidance, I highly encourage you to reach out to your local health department. I don't have that information. So this is going to be completely enforced and run by the health departments. This is outside of HCPF's purview. What we were able to do was confirm with the health departments that day programming would be considered a limited healthcare setting because the assistance with ADLs and having a nurse on staff and things like that. But the specifics are going to have to go straight to the health department. All right. I don't see anybody typing. Do we have any other comments or questions verbally? Okay, not hearing any. We will move on. Next slide, please. Okay, so specialized adult day services. So I want to remind folks that we have two different types of adult day services. We have our basic, and then we have our specialized. And specialized is for those that have that serve members, and I want to say it's like over 50%, and I don't have the exact number in front of me, I'm sorry, but have a high, over at least half of the members that they serve have certain diagnoses that require significant therapies and medical intervention. And so specialized adult day services, those settings are required to have a nurse on site during the whole time that they're operating. And so that's what makes them different, and it's differentiated from basic. So I want to reiterate that specialized adult day service providers may continue to be provided either in person or using telehealth during the public health emergency. This is an allowance that we have provided for the public health emergency. I will also remind folks that the administration actually just extended the public health emergency. It was set to expire on October 26th. It has now been extended to January 23rd, I believe. Don't quote me on that exact date. I heard somebody mention it's Inauguration Day, so whenever that is actually. So there is actual extension from the federal administration around the public health emergency. So we did not include the specialized adult day services within the three-tiered structure. These services are more intensive, and they have the additional requirements, as I mentioned, around nursing. Nursing services through telehealth is actually considered telemedicine, and HCBS services cannot be reimbursed for telemedicine. So per Senate Bill 20-212, telemedicine is pretty clearly outlined and defined within that statute, and so HCBS services are limited to telehealth and not telemedicine. So we do not provide telemedicine. There is a clear distinction. It's the difference in the clinical services provided. We do not provide telemedicine under HCBS. So with that, what we were thinking is that specialized adult day providers that want to bill in the 15-minute units or wish to continue the telehealth options post-pandemic, so after the public health emergency ends, that you may do so as a basic adult day service. You may bill the basic adult day service tier 1. That was a mouthful, and I don't think I wrote that sentence very well. But essentially, if you want to provide those services, you may provide basic adult day services. So you will not be held to the specialized adult day standards for tier 1 if you were billing those. But you cannot bill. There will not be a separate tier 1 specialized adult day service rate. That was a mouthful. Next slide, please. Now let's talk about it. So what do you, as specialized adult day providers, what do you see as that you'd like to have as an option? Or let's see here, do you like to have the option to continue to provide telehealth services post-pandemic? Is that something that you would like to be able to continue to offer to your members? What other issues or obstacles perhaps are you seeing as a provider around this option? What impact would this approach have on the quality of services that are provided? And are there any other changes that might still need to be made or suggestions that you all have as we are considering pushing this policy forward long term? So with that, I'd love to hear from some of you if you want to type in a question on the chat box, or we are happy to take questions verbally as well. Any questions, comments, feedback? I see Michelle typing. Anybody on the phone or computer? Not hearing any. I will wait for those chat box comments to come in. Just sitting on pins and needles. Let's see who can type faster. Totally kidding. All right. Sorry, folks. Okay, Michelle. Thank you, Michelle. Okay, so given that guidance, I'm not sure where to go, but I do think specialized adult day does need some ongoing flexibilities to stay sustainable. So that's helpful, Michelle. My question back to you would be, knowing that you wouldn't have to provide nursing services as part of your tier 1, would that be something that you all would be interested in providing? So continuing to be able to provide telehealth or technically in-person tier 1, but as a basic adult day provider instead of the ongoing nursing services. Is that something that you all would be interested in? And then Tracy mentions, we currently have 14 clients all wearing masks and social distancing, 4 staff to 1 client. Okay, I'm not. Is this part of a specialized adult day services, Tracy? And is this the folks that are, do you have more folks that are not wanting to come back, or do you want to come back but you're only able to actually bring in 14 people? Love to hear a little bit more about that comment. They're both typing again. Okay, so Michelle responded to my question to her. You would think that, or I would think that we would need to think that through because we still need to provide the cost of the nurse for on-site, so we would need to weigh the budgetary implications of doing that. I totally understand that. I think it could be doable, but I would need to process that with the new lens. That makes sense. So, one of the things to think about, Michelle, would be you could provide in tandem, you could be providing on-site Tier 2 services or Tier 3 services with your nurse and, typical business as usual, especially right now with the limited capacity. And then you could also provide Tier 1 services with different staff, like perhaps you're operating at 50% capacity, so you still have some staff that are available because you can't bring in as many folks as you normally did. They could provide the Tier 1 services at the same time, so that might be one option to kind of look at how you could make that work. But I appreciate the honest feedback. Okay. Let's go ahead and move forward just so I can kind of go through some of these slides, and certainly want to make sure that folks still have an opportunity to provide feedback and around this topic. So Tracy said, only 2 people not willing to wear masks, so they served with one-on-one. We utilize SCE and spec. Okay. Okay, so that's more of the rehabilitation and IDD waivers. Thank you. Okay, so while folks are still providing comments, please don't, stop providing the comments. I'm going to go ahead and move on to some of the proposed regulation changes to help with the conversation here a little bit. So with this, obviously, as I stated, we are hoping to keep some of these flexibilities and these changes long-term. And long-term in my brain is post-pandemic, because I have no idea when that is, right? Pre-pandemic seems like, I don't know, 15, 16 years ago, something like that. It's such a different world. And so with that, we have to make changes both to our waivers and actually to our regulations. And so we wanted to show you some of the proposed changes that we are looking to make to regulations. Our goal would be to have no gap in these allowances and being able to provide them long term. So currently we have what is called an Appendix K, which is essentially our disaster appendix that CMS, the Centers for Medicare and Medicaid Services, has for all states for specific disasters where you can make certain allowances, you can make quick changes, things like that. All states have submitted Appendix K as far as I know for the pandemic. However, the Appendix Ks are limited to only actually a year. So ours is set to expire on March 10th at this point in time. Whether or not that gets extended because we've never actually had a pandemic within waivers, we have no idea. But for right now, we're operating on the timeline that Appendix K, so these current allowances, end March 10th. So our goal is to have all of these changes in place so that it is a seamless transition and they just continue indefinitely. It is not something where we have to stop and then make these changes and then we go back to this. We want it to just continue. So with that, we're on a fairly tight timeline with both our waiver amendments and our regulation changes. So as part of these stakeholder meetings, we wanted to throw out some of the changes that we're looking to make to regulations to go ahead and start gathering some input from you all. And then we'll have an actual draft that we'll send to you. But so here are some of the proposed changes to the regulations. I see more comments coming in the chat, and I'll get to those in just a second. So proposed changes to basic ADS, we would actually separate out the different tiers within the regulation. So we would call out what each tier is with a definition and limitations and things like that inside the regulations themselves. So from Tier 1, what we would do is we would completely remove some of the requirements that are under Tier 2 and 3, which would be assistance with ADLs. That would only be for those when Tier 1 is provided via telehealth. So if Tier 1 is provided in person, it would still have that requirement. So we'd make that distinction within regulation. We would remove medication administration, nutrition services, the provider environment roles and responsibilities, because if you were not bringing somebody in-house to a facility, you are no longer responsible for the environment. Food safety requirements. Next slide, please. So those are the things we're looking to remove from Tier 1 that will remain for Tier 2 and 3 that currently exist today. Some things that will still be required that we are planning on still putting under Tier 1 are things like community integration and meaningful activities. That is super important. Social and recreational supportive services, a participant's right to choose not to participate. And this is actually a little bit bigger that I want to hit on a little bit in the next slide. Medication monitoring, so that will still be required. However, administration will be removed. Records and information will still be required for Tier 1, but it will now include virtual services and care planning. So care planning is going to be big, and it has to include the service delivery preference of the member, and then the actual schedule of the virtual or in-person services. Next slide, please. Again, so this list is a little bit longer. So still also required under the Tier 1, we will still require critical incident reporting. There will still be staffing requirements that will be updated to include the virtual services. Training requirements will be included. That will now include training on providing adult day services through telehealth. Written policies will include telehealth service-specific policies. And then reimbursement method of ADS will be updated to include Tier 1 billing structure and limits. Next slide, please. So same, and I'm going to run through this one too so I can get to my questions slide. So for the brain injury waiver, we also have to make some additional changes, and these are the changes that are proposed right now. Still separating out the Tier 1 and Tier 2 options. For under Tier 1, we will remove the certification standards of the center since the services will no longer be provided in a center. That will not be required. We'll separate out the requirements between Tier 1 and 2 around staffing requirements and then updating policies based off of tier level. So for example, meals and nourishment that will be provided. We'll create regulations for Tier 1, which will include virtual monitoring of clients to ensure hygiene is met, meds are being taken, nutrition is sufficient, things like that. Next slide, please. Okay, this is one I wanted. Feedback on proposed changes. So I just went through a whole lot of ideas and proposed changes to the regulations. Are there other requirements that need to be modified on the tiered structure? So are there other things you want to see in regulations that I did not mention? One thing that I really want to hit home is we're going to have a whole section around protections for members. And I'd be interested to hear from you all around what protections you think make sense to put in regulations. You know, obviously the clear one is a member is never required to do virtual services. If a member prefers in-person, they have the right to receive in-person services. And so we're going to have some very clear instructions or protections around that. But what other protections would you all see that need to be added to regulations? Are there other changes that the department should consider for adult day services in general when thinking about regulations? And are there things that should be added to the regulations based on the new tiered structure? Okay, that was a lot. I'm going to go to the chat box. I'm going to go back up to where I think I left off. Okay, so Michelle was still, following up on the conversation around the specialized adult day services. So I appreciate that, Michelle. And it says we are providing that for clients. I think she's talking about the telehealth that aren't ready to come back during the pandemic while operating. It is a lot with the pod set up and maintaining social distancing and trying to stay safe. I totally understand. The current operations right now for offering the variety of services is really difficult and is a lot for a lot of providers. Lori's asking, can we bill for both? Tier 1 for virtual programming and then specialized for those who choose to come back to the program and get the same level of service they received before COVID? The answer is yes. So if you are still providing specialized services in person in a facility, you may continue to provide those. Also offering the virtual Tier 1 services, knowing that those aren't specialized, but you may provide both options and bill for both options, absolutely. Michelle, during the pandemic, we can bill for the specialized rate. This would be post, yes. So yes, you may still bill during the public health emergency. You may bill specialized adult day services if you're providing them via telehealth. Keep in mind, you still have the unit limits. It has to be a minimum of 3 hours. If you want to provide services or bill for anything under 3 hours, you would have to bill at the basic rate. But yes, as far as the majority of the conversation is post-pandemic. All right, Prima to adult day, what do you recommend we do with a client who wants to be in contact but not able to learn computer tablet technology due to their mental state and simply don't have anything other than phone? Can we bill those clients under Tier 1 for telephone communication? That's a great question, and it's one of the things as we are considering how we are going to roll out telehealth options for a variety of HCBS services. Actually, we're looking to make this a long-term option for many, many of our HCBS services. What we are doing research on is, best practice. Can a telephone only work? And I think perhaps it can. It would likely just need to be a little bit more limited. We have concerns about only talking to somebody over the phone because there are a number of things that get missed that you see visually as far as the person's well-being, their nourishment. Oftentimes you can tell if somebody isn't taking medications, or there's just a lot that you can garner from a visual interaction as well. And so I think that is a really great point, and perhaps something that can be added to regulations around how telehealth can be provided, that it may be via a video conference or via phone. Perhaps if they have a phone, I don't know if they have a smartphone, maybe FaceTime would be an option so you could see the person. May not be an option, and I understand that, but it's something that we need to think about, and perhaps we still need to allow so those members can still have some contact, which I think is really important. But it might be slightly more limited is what I'm just thinking off the cuff here. I don't actually know. But I'd be interested to see what you guys think. Let's see here. Another question from Prima is, many of our clients received increase in their food stamps and asking about their attending. Yeah, so I think I answered that earlier. I don't know. I don't know the answer to that question, and that is not something that we actually oversee. We don't manage food stamps within HCPF at all, so that would have to be a county question. Tracy mentions tier changes. I'm not entirely sure what your comment means. I'm really sorry. An increased care. I'm not sure what you were trying to say there, so hopefully you can help me understand a little bit better. Alex mentions here, telehealth needs to include both a telephone and a video chat option. Many clients would be completely isolated if you take regular telephone out of the equation. Great point. Thank you, Alex. What I'd be interested to know is, should there be additional limitations, though, on the telephone? Because it's harder to engage, I think, for some folks just via telephone, and maybe not, versus a video chat for longer periods of time. Tracy? Here, maybe components have had some increased severe behaviors that fall out of their current tier level. I'm sorry, Tracy, I'm just not following. Perhaps maybe if you have a microphone on your computer, or if you have called in, perhaps you could ask your question verbally. And speaking of that, is there anybody that wants to speak up and talk about the tiers or these proposed changes to regulations, or any other feedback or comments or suggestions on the regulation changes? Anybody verbally wants to add in? Okay, not hearing any. I will go back to the chat box. So Tamara has asked, oh, I'm sorry. Oh, no mutes are on. Okay, sorry. I was getting a message about it. It said that everybody is muted, but nobody is muted, so you should be able to speak up if you are interested. So Tamara has asked, are SEPs aware of these changes? We have approached ours to start to make these changes in the service plans, and they state they are unaware of these changes. Any suggestions? That is really interesting and unfortunate. They 100% should be aware of these changes, as we have notified them. If you have a specific agency that you are having difficulties with, please reach out to us directly so that we can perhaps provide some direct and specific technical assistance to that agency. You are always welcome to send the case managers a copy of the memos. They are all posted online, and the memo clearly outlines these allowances. So perhaps you could start there, or just reach out if we can provide any assistance there. Alex, let's see here. In response to my comment around the phone, it says you could add that video chat option are preferred over pure telephone and should be used whenever possible. I like that idea. Thank you, Alex. And then Rob asked, if we were to provide specialized habilitation in a host home during the pandemic, what tier would that fall under? So Kira, help me out on that. I think we had said tier 2 for that. Keep in mind, though, The tiered option has been rolled out for the 4 non-IDD waivers, so elderly, blind, and disabled, community mental health supports, spinal cord injury, and brain injury waivers. Because of the different structure and the different way that services are currently provided under specialized habilitation in the IDD waivers, that has not been officially rolled out yet, because we have to figure out a way to provide the flexibility and the options while maintaining budget neutrality, and we are still working on that. So that has not been rolled out yet. So Rob, to answer your question right now, you would bill for services as usual, as long as it has been approved. All right, what other questions do we have? And you're welcome, Rob. And I'll just let you know that we actually, based off of stakeholder feedback, because I do know we have a couple of IDD providers on this call here, based off of our last meeting and stakeholder feedback, we are actually going to host another meeting on October 22nd. More information will come out. That will be on the website, constant contact, all of that. But just to give you a heads up that there will be more information coming. What other ideas or suggestions do you all have around regulations? Do you think that this is sufficient? Do these changes make sense? Is there anything that we missed that you'd like to see? Any thoughts? Feel free to speak up on the phone or in your computer as well. Okay, so not seeing anybody else typing and not hearing any verbal comments, I'm just going to go ahead and move us along here. Next slide, please. All right, so the next steps. So just to let you all know the process of what we're going to do going forward. This is actually the last meeting that we have on the books for adult day services. So again, the non-IDD waivers. So the next steps, please continue to submit any questions, comments, or additional feedback you may have to that inbox that's listed right there. We are working on updating the waivers to reflect this new structure. We are also working on drafting the regulations that will reflect this new structure. Once we have a draft of the regulations, we will put it out for public comment. We'll probably send it out via constant contact and post it on the website somewhere. So just be on the lookout for that. If you are not part of that constant contact, please be sure to sign up for that. Let's see here, Kira, hopefully you can post how they can sign up for that. Or you can just reach out to John Berry. John, and they corrected me earlier, not all state employees are first last name. John Berry is actually john.r.berry at state.co.us. You can reach out to him and he can add you to that distribution list as well. And so the areas within the regulations that we're looking to update are the 8.491, so the volume 8 regulations, and then 8.515.7. So those will be the areas, the regulations that will be updated, will be going to Medical Services Board. Once we have drafts of those, as stated, they will go out for public comment for you all to provide additional feedback on those regulations. Again, we have a super tight turnaround time because we really want to make sure that there is not a gap in these new flexibilities and that we can just roll this out and continue it post our Appendix K approval. And thank you, Kara. She provided John's email, so if you want to get on the distribution list for the constant contact, which also will get you on the distribution list for any memos that we publish. It's a really, really helpful ping, I think. I'm actually on it, which I find really nice, so I always know when memos go out. So it's been really helpful. Okay, next slide, please. All right, so we are wrapping up, and we're pretty early, which, you know, for the most part, most folks don't dislike. Do we have somebody on the phone that wants to say something?
Yeah, hi, it's Alec here one more time.
Yeah, hi, Alec.
I hate to sound like a broken record, and as I said it before, you know, the changes you guys introduced are great and definitely helpful, but I don't think there are many businesses that can survive running on less than 50% capacity. So my question again is there anything above and beyond that you guys are considering? I know we talked about the issue of 50% state retainer payments. There are some technical difficulties. Just wanted to see if there's any movement there, but more importantly, encourage you guys to, look at other options, because as we said, what you guys have done so far is great, but is not sufficient. Um, you know, as I've said before, think about our business almost like a restaurant. You can't have a restaurant that consistently has less than 50% utilization and expect it to run profitably and be around when this uh, pandemic uh, finally, hopefully, subsides. So if you want to have data providers to still be around after this, I think there's more needed. So, I would appreciate any updates on state retainer payments or perhaps any other initiatives that you guys might be thinking about.
Sure. So I appreciate that. And Alec, I will tell you that we have dug into the idea of the 50% state retainer payments, and it is just not a viable option. Because of these are so intertwined and tied to the federal system and the prior authorizations, it would require massive changes to members' service plans and their PARs, their prior authorizations. In addition to that, we actually don't have a system that would be capable of providing this. So we would have no way to pay providers for this. That our system isn't built for that. It would require a whole bringing up a whole brand new system, which we just don't have the funds for. So the 50% retainer payments at this point in time is just not a viable option, because it would actually cost the state a significant amount of money to be able to implement that. And as you know, we don't have any of that, meaning money. So what we did was, once we have realized that, we have been putting all of our effort and resources into finding more options and flexibility for you all. This is what we came up with. Just to be clear, the resources that we have for these services are Kira, myself, and Cassandra Keller, and we all, as you know, I actually manage the section for all HCBS services. So those are the resources that we actually have available to us within the department. So it is not a lot. It's 3 people. Essentially, that have a lot on our plates that are trying to come up with other options. So this is what we are able to come up with. I would love, if you have other suggestions or ideas, please bring them forward, because that's what we've been desperate for. Is, if this isn't enough, and I hear you, operating at the 50% capacity is difficult. Keep in mind, again, that is the public health department implementation in order to keep members safe. If you have other ideas or suggestions outside of the 50% retainer payment, please let us know, because we would love other ideas. This is the best that we could come up with for right now. So keep racking your brain and keep thinking, and as you come up with other ideas, please send them in. And that's for everybody, not just you, Alec. So I see a couple other questions.
I don't know.
Sorry. Go ahead.
Yeah, just as a follow-up, on the IDD side, I want to say 3 or 4 or 5 years ago, who remembers, there were like one-time incentive or bonus payments that were given based on, I'm actually not sure I remember what they were based on. So, even a one-time payment that is loosely based on, I don't know, attendance or pre-COVID capacity or something like that.
Yeah, the problem
we're getting
is,
really desperate
with something like that is actually not going to be budget neutral, and that would cost the state additional funds. And right now, considering the state as a whole is facing a $4 billion shortfall, there's just no way for us to provide any additional funds.
Yeah, but I think if you look at utilization, right, if you look at daycare utilization, it should be, unless I'm completely mistaken, it should be down significantly, right? So all we're talking about is just finding a way how these presumably unutilized funds can be redeployed.
Yeah, and that's not how the legislators and the Joint Budget Committee has actually worked on the budget. So I think it would have to be options that we could ensure would be budget neutral. So it would not be authorizing any additional funds on top of what we currently pay. So So I hear you, and I have heard that many times around the utilization, but we don't have any way to actually categorize that, nor can we utilize those funds per the Joint Budget Committee. So I'm going to go on to the next comments in the chat box here really quick, and then if other folks have comments verbally, happy to take them as well, of course. Let's see here. So Rob is asking if the tiered system is going to be applied to supported employment at some point in the IDD waivers. You know, Rob, we actually have not considered providing the tiered system to supported employment because it just wasn't something that we had actually heard that there was a need for. We are considering and looking at the telehealth option for supported employment, and there already is an individualized supported employment service, and so I'm not sure that there's quite the exact same need for the supported employment, but I'd love to hear more about that if you have ideas. Janice had mentioned, just to clarify, will the 1022 waiver webinar, looks like Kira answered that, the 1022 webinar, just so everybody can hear as well, just in case you're not on the webinar, is specific to the IDD waivers, which is going to be around specialized habilitation and supported community connections. And again, that was a follow-up unplanned stakeholder meeting that we have added to the calendar based off of feedback that we received at our last meeting. There just wasn't enough conversation and we needed to have more, so we went ahead and wanted to make sure we got that on the books. Any other questions, comments, thoughts? Again, there's the contact information. If you have anything after this meeting, this is not a one-stop shop. Please continue to send in your questions, your comments, and your feedback. We really, really appreciate hearing from you all. Let's hear, Rob has another question. This was more whether or not we would be able to provide in a virtual manner and be able to bill for it. So Rob, that is the plan, is that supported employment would be able to be provided via telehealth options, and that is part of an initiative that we're looking at to have telehealth ongoing long-term for a variety of our current services, actually, and we have a separate stakeholder process for that specifically. Any other questions, thoughts, comments? Anything else anybody wants to offer? We have quite a bit of time left, but no need to just sit in silence if you all are good or don't have anything off the top of your head. So with that, I'll go ahead and wrap us up, and I just want to thank all of you for your time, all of you for your commitment in providing these services and helping us think through what is now being dubbed the new normal, how we are going to continue to support members in the best way possible. You guys have all shown up to the table in remarkable ways, and you know, our state is certainly a leader in the way that we are able to support providers or members because of such innovative and amazing providers such as yourselves. So we really want to thank you for your continued innovative thinking, your continued innovative service delivery, and please continue to reach out to us if you have questions or comments. And we look forward to continuing to move forward and implementing a lot of really new great flexibilities. Thank you all for your time. I hope you have a wonderful afternoon.